Welcome to the Vet Dental Show. I'm Brett Beckman. I'm a board certified veterinary dentist, and we come to you every week on Wednesday to provide the veterinarian and the technician team some actionable things that you can use in your practice. And this episode is going to be a recorded episode that we've done in the past, not a podcast that we've recorded or not the Vet Dental Show, but actually some other information for you that we know you're going to enjoy. So sit back, enjoy, and we'll see you at the end of the podcast. JT Narell, relevant to all surgical cases, how do you do effective caudal maxillary blocks when the upper tens are missing or there's bad perio? Local doesn't work apparently in inflamed tissue, and that's absolutely right. Inflamed tissue alters the pH and the characteristics of the block and its ability to cause the desensitization of the nerve. So inflamed tissue neutralizes or almost eliminates the effect of a block. That's why we do regional blocks, because if we're away from the area that we're working on, we do that block that hits that nerve before it innervates the inflamed area, and consequently it allows us to stay away from the places that we're at and work on the inflamed areas without worrying about whether the block's going to work or not. So the question was, if there's no 10 there in the maxillary block, if 210 or 110 are not there, how do we do the block? Well, it's not necessarily the tooth as much as where that hard palate ends. So you can still palpate where that tooth was, because that shelf of bone stops at the distal aspect of 109 and 110 in a dog. So you palpate until you get to the point where you feel that soft palate starting from the hard palate adjacent to that tooth, and that is the location for insertion of the needle. And I would warn you, do not try that. If you're just hearing me describe that now, do not try that without looking at the proper technique and practicing that on a cadaver. You do not want to go up very far at all with that needle. You only want to go barely into that tissue, because all those neurovascular structures are just right above the palatal mucosa there. You don't have to go but 1.5 to maybe 3 millimeters in a large dog, but no more than that. And actually, you probably, when you pass that needle through, it probably goes too far as it punches through the tissue. So the best way is to punch it through and then bring it back a little bit and kind of get a feel for where you're at, because you do not want to be high and dorsal with that block, because you have all those neurovascular structures there. You can cause laceration, you can cause bleeding, and you can also get it too high, get into the suborbital tissue, and there's actually been cases where somebody has impaled the globe, and it resulted in uveitis and eventual extraction removal of the eye. Sorry about that. Removal of the eye because of the uveitis that could not be controlled and the damage that was caused. And that's multiple cases. So I want to make sure that you know what you're doing there. It's one of the safest blocks you can do, as long as you know how to do it. And they're all extremely safe. They're all very predictable. So hopefully that answers your question. All right, Caitlin, so what is a dentin chalk trail? And could you show us a picture or video of this? I wish I had that, and I've got that in my things to do, Caitlin, to do a little video of that. I looked online to see if I had it posted with my name, and then I looked online in general. Could not find anything that would demonstrate that. But essentially, it's like if you had a hard table made of let's say vinyl, and then you had a piece of chalk, and you took your dental explorer and you ran it across that table. It's going to be a frictionless surface for the most part, just like enamel. But if dentin's exposed and there's no tertiary or reparative dentin that's come in to create that enamel-like dentin, then when you run that explorer across that that exposed dentin that's not healed, that is going to cause that chalk to disengage from the piece of chalk, right? So that's what we mean. You'll have a little, you'll be able to, if you have a magnifier on, especially in good lighting, you'll be able to see that little trail from that explorer tip that kind of brushes up that dentin that is now loose on the surface. So that's about as good as explanation as I can give without actually having the video to show you what I'm talking about. So good question. Jeanette, welcome back. Jeanette had a question last time or two that we addressed. So dogs with dentigerous cysts, if they're big enough, can be at risk for mandibular fracture. I believe that's your question. What is the recommendation to the owner, and how long should you expect new bone growth to fill completely? Good question. And yes, that is true. That there is a possibility that jaw could fracture. It's very slim. We're not really removing much bone except for on the vestibular side. The problem for fracture would be during the extraction. The problem after is almost non-existent, as long as that's not a dog that's falling downstairs or in dog fights or hit by a car or something like that. The bone grows back very quickly. You'll have good bone growth back in there by 6 weeks, whether you use a bone graft or a blood clot. And when we have those cysts, the reason why the burr is good is because you scrape that bone with a periosteal elevator, and sometimes you can peel that lining off. And please, let's qualify this by saying we're talking in general practice about small cysts. That one that I showed you with the post-op, that would be as big as you want to do, and that would be pushing it. I would not recommend you do any others, and you may even not, if you're not comfortable extracting mandibular canine teeth, do not even do the one that I just showed you, because that tooth, if that cyst wrapped around the lingual side of that tooth and you couldn't get to the cyst, you've got to extract that mandibular canine tooth to get to it. So if you can't extract comfortably a mandibular canine tooth, don't even think about doing a case like that one. Also, that one that we showed, if the canine tooth is not involved, that's as big as you want to deal with. You do not want to go in and do these. So Sarah, in response to that question, speaking to the general practitioner, the periosteal elevator is the main instrument that we can use to peel that cyst off the wall, and the tooth for that matter, gently. But I like to go back on the walls with the diamond football burr and just make sure that there is no cyst remnants on those walls. And whether that's overkill or not, I don't know, but I do that routinely, especially if it's where I can't see. I mean, some of these go back into the mandibular canal, destroy the canal, or destroy the canal remnants, and actually, and I think Boris was one of these where there was cavitations back in that caudomandibular part of the cyst in the body. So you don't want to get involved with those. If you can't see, that is a really good way to kind of double check just by feel to see it, to make sure that you've smoothed that bone, even if you can't see it, and hopefully remove all the cyst remnant. And I probably gave you too much information there. That's not something that you would be doing in general practice. Sharon, good question. Mandibular canine extraction, what luxator or elevator do you use, and first approached after envelope flap to make extractions easier? lastly, on this case, would you apply a bone graft? So with our luxators and elevators, those used to be two different instruments. You used to have the luxator that went down into the periodontal ligament space that was thin and was effective, real effective again at that, real effective at that, kind of like a periotome. It was, but it could bend. So we wouldn't use the old luxators for elevation. The elevators were thicker than what we use today and were used to kind of brutally elevate, and you could put a lot of pressure on those without bending them just because they were thick. They weren't that good of metal, but they were thick. The other problem that we have with luxators and elevators more present day is that you can't tell what the number is on those things. They're so small. They're written on there so small. And so combined with the better materials of stainless steel and combined with the properties of that, we're now able to combine luxators and elevators with one product. So one luxator / elevator, and we went a step or two further by making it easy to see which one you need. And the need is based on the diameter of the tooth that you're working on. So a number one would be for a cat distal first molar root. It would be for a small dog incisor, possibly. It would probably be too big for a cat incisor extraction, except the maxillary lateral incisor. And then you go all the way up to, say, a 4 or 5, and those are more for canines and mandibular first molar root. So whatever the diameter is of the luxator or elevator, that is the diameter that you would choose to use for that particular tooth. I trust you enjoyed that episode. We enjoyed providing it. Take care. We'll see you next week.